thank you, Conceptual, for allowing me to come and share uh, my talks. I'm a physiotherapist by background, and I've been practicing for now more than 20 years. So I think what's important is that the teamwork between orthopedic surgeons and physiotherapists have to be good for us to have good clinical outcomes with our patients. So today I'll try, in my first introductory lecture, try to go over basic aspects of what physiotherapists do, a lot of terminology that we use, and introduce you to that terminology. In case if you have any questions about physiotherapy practices, terminologies, or what we do, what is the current evidence about the various practices that we have, please go ahead and ask questions about it. So today's agenda that I thought about that I'll cover today, I'll be talking about basically how a physiotherapy evaluation is done. How is it different from an orthopedic evaluation? What is the role of electrotherapy? I'll introduce you to a lot of PT jargon, which may be new for some of you, and some of you may know those terms, but we'll just go over those things so that it's easier for you as an orthopedic surgeon to communicate with your therapist. And just talking about how do you work as a team together. So to start my lecture, I just wanted to talk about how physiotherapy evaluation is usually done. It's very similar to an orthopedic evaluation. To initially, like when you were to come, you would observe, you would palpate, move, and measure. That's so the basic concept of evaluation of patients remains the same for us, but the orthopedic labeling or the diagnostic labeling, which is done by orthopedicians, are not sometimes useful for us. So I'll give you an example. So suppose a patient comes to you and presents with shoulder pain, which has been there, let's say, through an insidious onset. There's no history of relevant trauma, and the person complains of pain while raising the arm. So you see a painful arc. You find that the person has positive Neer's, Hawkins, and Job's test. You do not find any weakness in rotator cuff muscle performance, and you do not find um, any other problem which could indicate, let's say, an instability or slap tear. And you would say, yes, I think this patient is possibly a case of shoulder impingement. And when you think that the patient is not a patient that you need to operate on, then that patient is usually forwarded on to the physiotherapist for further management. And in that case, so for most conservative care for soft tissue problems, a physiotherapy management comes forth. And a patient with a label of impingement, when it comes to the physiotherapist, of course, I'll redo those evaluations that you do, but there are certain extra things that I need to know, because this labeling of impingement does not help me. It does not tell me what I should do to treat the patient, right? For an orthopedic management, as soon as you are okay that the patient is not operable, you give medicines, advice, and then refer to a physiotherapist. And at the physiotherapist, I need to know why shoulder pain developed in the first place. So there are a lot of evaluations that I need to do in terms of which muscles are, let's say, weak that I would need to strengthen, or which muscles are tight, muscles or soft tissues. So I'll possibly in my shoulder evaluation look for strength of serratus or lower trapezius. Those are the important muscles for scapula. And I do not think that orthopedic surgeons usually in their clinic go about testing the strength of muscles. That is something what a physiotherapist does. Because as soon as I identify that there is a weakness of these muscles, I know that I have an exercise prescription made to strengthen these muscles. Do I look for pec minor tightness? Do I see for dyskinesis, which is a movement impairment? So let me introduce all of you to the terminology that we normally physiotherapists use, which is called as a movement impairment based diagnosis. These orthopedic labels do not help me. Suppose, give you another example. A person comes to you with knee pain, and knee pain, which is, let's say, not after your initial investigations and examinations, you think is not an operable case and needs conservative management, then is referred to a physiotherapist. So beyond those special tests and the regular orthopedic evaluation, I would be interested in knowing how is the strength of his quadriceps and his gluteus medius, because now I know that a muscle weakness can change the biomechanics for that joint, and it makes that joint more prone to repetitive overuse problems. So, for example, in this figure over here on the left, as you can see, there is a patient over here which has a pelvic drop while running. So, a lot of my evaluation is done while the person moves, and I try to identify these movement impairments. These are interesting. I believe also from an orthopedic perspective, I see so many orthopedic surgeons sending me patients who have dyskinesis or who have this patellar problem associated with a femoral rotation or a pelvic drop. Um, or to give another example, any patient, most commonly, as you see, for low back pain. And once your initial red flags are um, removed, like you sure it's not a pathology, it's not cancer or TB, or it's not a major disc problem, if it's a non-specific low back pain and it needs physiotherapy evaluation and is sent to me, above and beyond your evaluation, I'll need to find out how is the function of the muscles surrounding the lower back. So I'll possibly evaluate how is the core muscle strength. And I see a few orthopedic surgeons also doing it. So that is good. So what is important is I, as a physiotherapist, do certain extra evaluations on my patient to know whether the person has any movement impairment. So the orthopedic label of impingement or low back pain or patellofemoral pain is not useful for me. I need to know what is causing that. And if I know the cause, then I know how to treat it. So that is an extra piece of evaluation that we physiotherapists do, which I think could be useful for orthopedic surgeons as well. The second thing I wanted to talk about, the role of electrotherapy, and that is the most common prescription that we get from orthopedic surgeons for any pain management is surgeons tend to write IFT, TENS, SWD, and they send it to the physiotherapist for management. And what does the evidence say? Well, there has been mounting evidence regarding the fact that electrotherapy possibly is no better than placebo in managing pain and other symptoms in most orthopedic problems. What I want to emphasize here is that these electrotherapy modalities will reduce pain in the short term, will give possibly certain immediate relief of pain. They're based on the classical works of pain gate theory. So if you know what it is, you are trying to give a competing stimulus. So generally these chronic pain are being carried from the receptors to the brain by these very slow nerves. So as compared to the slow nerves, I'm giving a competing stimulus of currents or something else, which needs to go to the brain, which competes with the stimulus of pain, and the brain doesn't perceive pain. But as common sense would say, this would act very temporarily, and that's what happens. So, of course, we do use these electrotherapy modalities as and when required. Suppose if a patient comes to me and patient has having so much pain that is not able to exercise, maybe I'll use these modalities to reduce pain in an attempt so that the patient becomes more conducive for doing exercises. But this can't be my basis for therapy. So if you have a therapist for whom you think you'd make a prescription for only electrotherapy, that is not going to be useful for the patient. So why is it still so popular? I think therapists charge for using these modalities. Orthopedic surgeons love to write these prescriptions and send it to the patients because the placebo effect. I think the exercises usually take time to show their effect. This shows an immediate effect, and because the placebo works, and in some conditions such as giving a heat pack or a cold pack, something which the patient can do at home as well, if I do it at the clinic, the pain is reduced. So why not do it? So of course, I'm not against electrotherapy. I'm just saying it is an adjunct to regular exercises. I'm also saying that it is on my discretion that I would use whatever modality I think is most suitable for that time. Let's say the person comes to me with a lot of muscle spasm, and I believe that the person would have improvement by giving some superficial heat modality like a hot pack. But that is my decision. So I would refrain orthopedic surgeons to write these prescriptions for physiotherapists, because the problem that happens is when a patient gets a prescription from an orthopedic surgeon for IFT, TENS or SWD, and I deny that to the patient, then there is a conflict, and that is not good. So it's better to be on the same page for both of us as a surgeon and therapist. Let it be my discretion whether I want to use an electrotherapy or not. And in most cases, I believe that any pain relieving modality, which is the superficial heat modalities that are there, like hot packs or electrical pads or uh, whatever patient wants to use, can be done at home and should be done at home as well as a part of home therapy. So it's not very physiotherapy clinic based treatment that I need to give to the patient, right? So electrotherapy is useful, I would say, but it has limited role. Coming on to ultrasound, which is also very a popular prescription for most people for their patients, has shown very limited evidence for effectiveness in so many cases, for tendinitis, for tennis elbows, for sprains, and ultrasound has been proven to be not so effective in the management. Ultrasound given with some kind of a pain relieving gel, which is known as phonophoresis, is effective. Of course, any pain relieving gel, when applied in 5 minutes and rub, it will relieve pain. I would say it's more common sense than any magic. So again, for temporary relief, ultrasound or phonophoresis may be effective, but it does not promote healing or change the management for any kind of soft tissue pathology. So refrain from making those prescriptions is what I'll say.